We will discuss in this lecture the subject of infection in bone and joint. Infection in the bone called osteomyelitis. It is either acute or subacute type or chronic type. As regards the organism causing osteomyelitis, specific types of osteomyelitis as tuberculous osteomyelitis or non-specific organism, which is the most common cause. About the acute hematogenous osteomyelitis, which occurs mostly in children, boys more than girls due to the severe activity, which predisposed by a history of trauma. In acute osteomyelitis, the source of infection varies from either infected umbilical cord in infants, boils, tonsillitis, and skin abrasions, which is an entry for the microorganism. In adults, the urinary tract infection indwelling arterial lines. In acute osteomyelitis, the organism varies from gram-positive organisms such as Staphylococcus aureus, Streptococcus pyogenes, and Streptococcus pneumoniae. The other type of organism, gram-negative organism, as Haemophilus influenza, which present about 50% in patients less than 4 years. Escherichia coli, Pseudomonas aeruginosa, Proteus mirabilis. In discussing the pathology of acute osteomyelitis, the site of infection usually at the metaphysis of the bone, preceded by trauma, combined with vascular stasis and stagnation of blood, followed by acute inflammatory reaction, suppuration with formation of pus, necrosis of the bone, and formation of the sequestrum, which is a vascular necrotic wound. New bone formation in trial for regeneration after necrosis. The final presentation, usually resolution of the disease. This picture illustrates the pathology of acute osteomyelitis, presenting the site of infection, which usually at the metaphyseal part of the bone, followed by formation of pus, which can be discharged outside the bone or to the adjacent site of the bone. Another picture of acute osteomyelitis of the hip joint, usually at the metaphyseal side of the femoral neck, followed by necrosis and spread of infection to outside the wound or to the synovium of the joint and formation of septic arthritis. In acute osteomyelitis, the clinical pictures usually presented by severe pain, reluctant to move the joint due to pain and spasm of the surrounding muscles, fever, malaise, and toxemia, which can be severe and fatal prognosis. Acute osteomyelitis in infants has a specific clinical picture. First, by failure to thrive and failure to gain body weight, drowsiness of infants, irritability, metaphyseal tenderness on palpation or movement, and decrease of the range of motion of the joints nearby the affected metaphysis, which is the commonest around the knee. The clinical picture of acute osteomyelitis in adult, the site of affection commonly the thoracolumbar spine, presented by backache, fever, presence of history of urinary tract infection or surgical procedure in the urinary system. The patient characterized by the extremes of age, old age, presence of diabetes, and immunocompromised patient. In diagnosis of acute osteomyelitis, which start by the history of the patient, followed by clinical examination, laboratory investigation including the full blood count test, erythrocyte sedimentation rate which usually is high, blood culture examination. By using the X-ray in cases of acute osteomyelitis can be normal in the first 10 to 14 days. The ultrasound examination in acute osteomyelitis has many signs: deep soft tissue swelling, periosteal thickening, elevation and or subperiosteal abscess, fluid which is adjacent to the infected bone, cortical erosion, and increased flow within or around the periosteum. In MRI examination, in cases of acute osteomyelitis, which has a very high sensitivity for the detection of osteomyelitis, normal MRI exclude osteomyelitis. The high sensitivity means that the MRI can overestimate the severity of infection. The abnormality on MR may also present even after the infection has begun. The last examination for diagnosis of acute osteomyelitis is aspiration of the pus and using it for culture and the sensitivity of the organism. This is a picture of acute osteomyelitis in the index finger, clinically presenting by swelling, redness, hotness, and severe pain at the site of infection. The radiological picture showing destruction of the bone by the infection. Acute osteomyelitis must be differentiated from other similar conditions. The first type must be differentiated is cellulitis, which is a common bacterial skin infection that presenting by redness, swelling, and pain at the infected area of the skin. If the cellulitis is untreated, it can spread and cause serious health problems. Good wound care and hygiene are important for preventing cellulitis. The second item, differentiated from osteomyelitis, is septic arthritis, acute septic arthritis, which is a painful infection in the joint. The microorganism reaches the joint by the bloodstream directly, or in cases of animal bites or compound fractures in road traffic accident. The acute septic arthritis symptoms, including fever, fatigue, and generalized weakness, inability to move the limb with the infected joint, severe pain in the affected joint, especially with movement, swelling due to increased the fluid within the joint, on aspiration it pure pus, worms in the joint is red, warm to touch because the increased blood flow. Another item to be differentiated from acute osteomyelitis is the sickle cell crisis. The signs and symptoms which can presenting in sickle cell crisis: anemia, periodic episodes of pain at the joints, episodes of extreme pain called pain crisis are a major symptoms of sickle cell anemia. The hand presenting by swelling and the feet also. Frequent infection due to decreased immunity of the patient. Delayed growth or puberty. Vision problems. The last item to be differentiated from acute osteomyelitis is Gaucher's disease, which is an metabolic error presenting by enlarged liver and spleen, hepatosplenomegaly, eye movement disorders, yellow spots in the eyes, no enough healthy red blood cells destructed, leading to anemia, extreme tiredness, fatigue, bruising in the subcutaneous tissue, and lung problems. The major signs and symptoms in Gaucher's disease including enlargement of the liver and spleen, low number of red blood cells, easy bruising caused by a decrease in the blood platelets, thrombocytopenia, lung disease, bone abnormalities as bone pain, fractures, and arthritis. The treatment of acute osteomyelitis including the supportive treatment for pain by analgesic medication and management of dehydration by fluids intake or intravenous infusion. To relieve pain and avoid the spasm of the muscles around the joint, splint must be used. The indication of antibiotics in acute osteomyelitis is highly indicated in the early stage to avoid subperiosteal abscess formation and progress of the infection. The surgical treatment including drainage of the abscess and debridement of any necrotic tissue, removal of any foreign body present at the site of infection. In cases of acute osteomyelitis, the complication can occur as septicemia, which is a fatal progress complication, metastatic infection to another sites away from the primary site of infection, complication of septic arthritis by the near joint affected by osteomyelitis, alteration of the bone growth in pediatric patients due to the effect of infection and hyperemia on the growth plate, which lead to bone deformity. If untreated acute osteomyelitis, it passes to a case of chronic osteomyelitis. A variant of acute osteomyelitis is a subacute osteomyelitis presenting clinically by long history rather than the acute osteomyelitis and passes from weeks to months, presenting by pain and limping, swelling occasionally occur, local tenderness at the site of infection. The subacute osteomyelitis pathology. The commonest presentation is Brod's abscess, which presenting in the cancellous at the metaphyseal parts of the bone by a well-defined cavity, presenting on X-ray presentation by a radiolucent lesion, presenting by pain, which can be drained as a surgical treatment of subacute osteomyelitis Brod's abscess. The treatment of subacute osteomyelitis, mandatory antibiotic, persists for 6 months, surgical treatment by drainage of Brod's abscess. Another variant of osteomyelitis is the sclerosing osteomyelitis or the non-suppurative osteomyelitis. It is a common complication after surgical treatment of bony fractures. Post-operative, in the early type within 3 months after trauma or surgical treatment of fractures, or late after 3 months. The chronic sclerosing osteomyelitis may follow acute osteomyelitis if untreated properly from the start, or complication after surgery which may start de novo following operation or compound open fractures. As regards the microorganism presenting in the chronic osteomyelitis, usually a mixed infection, Staph aureus, E. coli, Streptococcus pyogenes, and Proteus microorganism. The chronic osteomyelitis pathology presenting by either one or multiple cavities appearing in the bone, dead bone avascular segment which is called sequestrum, multiple opening in the cortex which is called cloaca. New bone formation is involucrum in a trial for healing at the site of chronic osteomyelitis. The histological picture is one of the chronic inflammation. This radiological picture of chronic osteomyelitis of the humerus presenting by multiple cavities, sequestrum dead necrotic bone, new bone formation or involucrum, multiple opening in the cortex, cloaca presentation. Photo picture of bone affected by chronic osteomyelitis with multiple opening of the cortex and chronic infection at the soft tissue around the bone. As regards the acute septic arthritis, the route of infection, either direct invasion to the joint from a penetrating wound or compound fractures, after intra-articular injections, or after surgical treatment as arthroscopy. Another route of infection is eruption of bone abscess into the joint. The third type of route of infection in acute septic arthritis is hematogenous directly by blood stream. In acute septic arthritis, the microorganisms presenting are Staphylococcus aureus, which is the common, Haemophilus influenza microorganism, Staphylococcus pyogenes, and E. coli microorganism. In acute septic arthritis, the pathology presenting in acute synovitis with virulent joint infection, on aspiration it's a pure pus. The articular cartilage can be affected by the bacterial toxins and cellular enzymes, leading to destruction of the articular cartilage and complicated by secondary ankylosing or osteoarthritic changes. Also, the pathology of acute septic arthritis can lead to complete destruction of the articular cartilage and loss of function of the joint. The prognosis of acute septic arthritis sequelae, either complete recovery and restoration of the joint function completely, or partial loss of the articular cartilage and affection of the joint function, or in severe cases end by fibrous or bony ankylosing of the joint and loss of the function of the joint complete. In cases of acute septic arthritis of the neonates, the clinical picture of septicemia are present by fever, failure to thrive and retardation of the growth, irritability of the patient, resistant to move the joint affected. The clinical picture of acute septic arthritis in children presenting by acute pain in single large joint as the knee or the hip or the shoulder, resistance of the patient to move the joint, increase in the temperature and pulse due to fever and septicemia, increased tenderness at the site of infection on palpation or movement. On the diagnosis of acute septic arthritis in the adult, which mostly affect the superficial joints such as the knee, ankle and wrist, which is the common site of infection in septic arthritis in adults. The laboratory and radiological investigation of acute septic arthritis in adults, including the full blood count investigation, white blood cells presenting by leukocytosis and increase the number of white blood cells, elevated erythrocyte sedimentation rate and CRP level, blood culture for detection of the microorganism and the antibiotic properly used in these cases. In the X-ray of acute septic arthritis, presenting by large soft tissue shadow around the joint affected, ultrasound examination of septic arthritis in adults revealed turbid fluid intra-articularly present, aspiration under complete aseptic conditions, showing full pus discharge, which must be sent to culture and sensitivity examination. Acute septic arthritis must be differentially diagnosed from another similar conditions as acute osteomyelitis, trauma by the history and examination, irritable joint, hemophilic patients due to recurrent hemarthrosis of the joint, in cases of rheumatic fever with history of septic infection in the throat, gouty arthritis by elevated serum uric acid level, and Gaucher disease with associated systemic affection of the hepatosplenomegaly and arthritis. The treatment of acute septic arthritis, including the general supportive measures by administration of fresh blood to treat anemia, proper antibiotic administration by intravenous route administration followed by oral administration of antibiotics, surgical drainage of acute septic arthritis indicated when the conservative and the general supportive measures failed to treat the infection, either by mini arthrotomy or by arthroscopic drainage route of treatment.